afternoon, everyone. Warm welcome to today's session of Rare Info series organized by Organization for Rare Disease India. I'm Dr. Deepa Bhat, genetic counselor and professor from JSS Medical College, Mysore. I'm delighted to serve as moderator for today's insightful session. Inborn error in metabolism, though individually they are very rare, collectively represent a significant challenge for pediatric and genetic medicine. Among them, small molecule disorders such as urea cycle defects, organic acidemias often require early diagnosis, prompt management, and lifelong multidisciplinary care. Their chronic nature, risk of metabolic crisis, and dietary restriction and layers of complexity adds to the treatment planning. With this backdrop, today's talk titled Long-Term Management of Small Molecule Diseases aims to delve into the best practices, evolving strategies, and real-world approaches in managing this condition. So we are privileged to have with us Dr. Anil B. Jalan, an eminent clinician and academic in metabolic and genetic medicine, who will guide us through the nuances of long-term care in these challenging disorders. So before we begin, a gentle reminder for the participants to put the question in the QA box so that it will be taken up in the end.
Should I start or?
Sir, I'll introduce you.
Okay.
So Dr. Anil B. Jalan, he is a metabolic and genetic expert from NIRMAN, Navi, Mumbai. He is a visiting consultant at Apollo Chennai, Apollo Belapur, and SRMC Chennai and Manipal University. So also he is experienced in medical and pediatric education, MD Pediatrics from Mumbai University, 34 years in practice, trained in metabolic medicine at 10 different European centers and universities. He has more than 80 publications to his credit, 4 books published, several lectures because through invited talks in CMEs and conferences, 17 chapters in 6 medical books. So over to you, sir. We are very eager to listen to you from your vast experience from your center.
Thank you, madam. Am I visible and audible?
Yes, sir.
Okay. So today's talk is long-term management. And what we are talking about is small molecule diseases, which means we are not going to discuss anything about lysosomal storage disease, peroxisomal disorders, and complex molecules like CDGs and lipoproteins, etc. So before we go ahead, let's get an overview what we really deal with in India. Now, I think there are some international participants also, and each country will have its own spectrum. And it is very important to establish the type of metabolic diseases that you see and how to plan for this. Madam, I am not visible. I think there is some issue. The camera has been switched off or something. It's there. Okay. So this is a small slide with what we see in Mumbai in our center. And more or less, I think this is true for all over India. And this is the spectrum that we see in critically ill newborns. Mostly we see conditions involving glycine encephalopathies, galactosemias, maple syrup urine disease, and organic acidemias like methylmalonic, propionic, and several others, urea cycle defects, and like citrullinemia and OTC deficiency. So this is a spectrum, and we see almost everything in India. I believe my friends from Sri Lanka and Indonesia have also joined, and they may be having slightly different spectrum, and it all depends on the ethnicity and kind of consanguinity they have. And let's see the numbers that we have for inborn errors, and today, like IEM Base, which is an app and good website to give information about inborn errors, it's easily available, freely available. Anybody can download it. And I think in June, when I delivered lecture at Indian Council of Medical Research, the number that was mentioned was 1995. So these are the numbered metabolic diseases where we have all the details like genes and their pathways and things like that. And they are divided into 26 groups. And today we will be focusing on one or two groups. Out of these so-called about 2000 diseases, which are treatable, they are mentioned in one other site, that is treatableid.org, and the number is 116 as of today. So this is the site anybody can download. Again, it is freely available. Now, if you see, in last 1 year, like before this, I had given a lecture in ICMR and same time in June. And that time we saw number was 116, and even today number is 116 only. So we have not really progressed too much in number of treatable diseases in small molecule I am talking, but we have progressed quite a lot in individual conditions. So what we can do for individual patients, that is evolving over a period of time. Now, this is a situation which differs from country to country. India has its own limitations, and our neighboring countries, our friends, face even more difficulties in sending sample and doing test and in getting timely reports and diet and medicines. So it is evolving in each country at a different pace, and we all need to understand how to improve that. Diagnosing is very easy, I would say. Nowadays, we have good metabolic facilities available. We have good genetic facilities available. So small molecule diseases diagnosis is rather easy. But the problem comes is when we have a patient who is critical, and now parents start asking, what is the outcome? What is the prognosis? How do we manage? How long we treat? Should we be stopping medicines or diet after some time? What will be the life of this child, like mentally or say physical growth? Will he be able to get married or she get married? And what will be about his or her progeny? So these are the questions people will ask. So let us have some insight into how do we manage in a long term. Acute management, I think most of the pediatricians will know. And even if somebody is not really very well versed with it, it is easily available online. Madam, can we go ahead with the next slide? So just click 2, 3 more slides. So yeah, so these are the uh, sites available. Number, as I said, is 1995. And next, one more slide, madam. Next. Okay, next. Okay. So when we face with a situation, small molecule diseases, this one slide I would like to really highlight is sometimes we believe or we are given to understand that there is one test which will diagnose everything. Say, for example, somebody is doing TMS, he or she will market, oh, TMS is everything and we can do any diagnosis, or GCMS, or say any other test. But that's not the situation. As a clinician, we need to understand that it's a complex situation. It's not just one disease. There are so many angles to it, and we need lot of other tests and investigations to complete the picture. So you may have something very basic, something like CBC and platelets, uric acid, liver function test. These are important. Then we have 5 basic parameters that we need: ammonia, lactate, sugar, blood gas, electrolytes, and ketones, what we call GALAC. And then we have some more advanced investigations like TMS, GCMS, amino acids, etc., etc. It's a huge list. And I think at our lab only we do something like 120 plus kind of different tests. Madam, next. So approach is whether it is acute case or a chronic case. For a beginner and somebody who is not really into day-to-day practice of inborn error of metabolism, following these charts or algorithms will be very helpful. So, madam, there are four more. We can go quickly over those. I am not going to discuss these. These are given in all the textbooks. So, this is not our topic of discussion. What I will be doing today is I'll take up 5 or 6 cases, depending on the time permitted. And I would like to highlight what we actually do instead of doing any theoretical discussion or any pathway discussion or any biochemistry. I will just focus on the clinical situations and to understand that what is done in practice and what we can do and where we stand. These cases will give you some idea. So this is the first case, a day 2 old male child born out of non-consanguineous marriage. And at birth, baby was floppy, no respiratory effort. Baby was put on ventilator, developed jitteriness and hypertonia later on, and had no evidence of sepsis. And we thought why it is so early, and is there anything which has started antenatally? Because within first 24 hours or 48 hours, we know there are 5 or 6 conditions, including glycine encephalopathy, pyridoxine-dependent seizures, peroxisomal disorders, serine synthesis defect, asparagine synthesis defect. So one of those should be there. And we started with basic investigations. CBC, platelet, blood gas, ketones, everything was normal. Ammonia was normal. Lactate was mildly elevated, which is expected because child had some seizures. Sugars were okay. So we thought it could be glycine encephalopathy, which is a small molecule disease confirmed by glycine levels. So today we are not discussing how to diagnose, but how to manage. And this child was biochemically suspected to have glycine encephalopathy. And we ruled out organic acidemia because glycine is elevated even in organic acidemias. And also in pyridoxine dependent seizures, so pipecolic acid was done, which was also normal. Genetics was done and it confirmed presence of GLDC gene defect, and a child was homozygous. So this is a group of condition, glycine encephalopathy, even though it is a small molecule, I would say the smallest molecule in our group of metabolic conditions. This is glycine. Now glycine is having a cleavage system, and this is the cleavage system. Can you go next, madam? Yeah, so there are so many genes, and this is the pathway. We are not discussing pathway, but just to show that it's not a single gene defect. There are 3 plus 5 or maybe more genes involved, and we need to understand each one separately. Next, madam. So the primary treatment which is started is sodium benzoate. Now, here comes the understanding what this disease is going to do to this child. The first question which parents ask once we say it is glycine encephalopathy, is this child going to survive? Will the child will be normal? And this is how I counsel them that in my experience, 99% of them will not survive. The number may change. Those who survive, say 1%, out of those almost 90% will be having severe neurological damage. So we are left with something like less than 1% chance that this child may be neurologically normal, but otherwise very high mortality and morbidity. Problem occurs is when we save this child and then this child goes home with lot of neurological problems. I have patients coming from Gulf countries like Bahrain and Dubai, and they are so retarded, like after 5 years 6 years also they are on either a wheelchair or just no head holding also, and child keeps on continuously convulsing. So when child is so seriously I would say clinically involved initially, we need to take a decision whether to withdraw support or whether to continue treatment. If child survives, which with efforts child will, then you have a very long life with very severe neurological damage. and absolutely no hope of having any good recovery. There is less than 1% chance that this child will really do neurologically well. So these things need to be discussed in the beginning. Some parents take decision to withdraw the support, and some parents say, okay, we will do everything and whatever comes. But it's important from a clinician's point of view that you document what you have counseled them. Here, a genetic counselor or a clinician comes into the picture to give a realistic, I would say, prognostic view of the child or the condition. Suppose we start treatment, the first medicine that is added is sodium benzoate. Now, in India, sodium benzoate is easily available even in grocery stores. It is used as a preservative, and it is something like a 20-gram packet. Now, this particular medication or chemical will be used almost lifelong. So we start in the dose of, say, 250 milligram per kg per day. We can increase to 500 or even more. And if it is better, child is doing well, we can reduce it also. So the range is quite big, from 100 to 500. It is given in 3 divided doses. It is quite hyperosmolar solution when you prepare. So I suggest a dilution. And what we do is one packet, that is 20 gram, is diluted in 80 ml of water, which gives 1 ml equal to 250 milligram. And the dose is 250 milligram per kg. So it becomes very easy, 1 ml per kg per day. And even that 1 ml or whatever quantity comes, you can dilute in water or some other medicine and give it. Many times children have vomiting with this because it is irritant. So we may have to give some kind of lansoprazole or whatever to suppress that acidity. But if it is diluted, it is usually tolerated well. This is also used in urea cycle defects and GAMT deficiency. So a clinician should be familiar with the use of sodium benzoate, and it does not require refrigeration or preservation because it is a preservative by itself. And 20 gram will last hardly for 10-15 days. So that's quite okay if we keep it outside. I have seen some people make small packets, and they go to a jeweler shop, make some 200 milligram, 500 milligram packets, and then they give it just like that. So this becomes even more irritant because now it is not diluted. So this is my suggestion. First suggestion, I would say, use it in a diluted form, keep it, no problem. Yeah, you keep, say, dilution of 250 milligram per ml. That's a very good, or you can dilute it even further. No issues at all. Madam, next slide. So glycine encephalopathy long-term treatment is basically sodium benzoate. Additionally, we use dextromethorphan. Unfortunately, it's sometimes not easily available. It is combined with some other medication, some kind of sedatives, chlorpheniramine maleate or something else. So just check it whether it is pure dextromethorphan or it is in combination. We need pure dextromethorphan. Dose is 4 to 5 milligram per kg per day. This is also long term, probably lifelong. And anticonvulsants, that's very important. Neurologist or a pediatrician probably will have started already some kind of anticonvulsant, which should be continued. Now, problem is here, we think that it is a glycine which is giving problem, and reducing glycine in diet will help us. That does not help because glycine is a non-essential amino acid. So if you give very low protein diet, there will be catabolism and release of glycine, and this will counteract your whatever formula you're given. So formula does not help here. It is available. So in emergency, yes, you can use it. But for a long-term treatment, I don't suggest any special formula which is devoid of glycine. Best is to give slightly low protein diet, but enough to maintain anabolism. So 0.75 to 1 gram per kg should be the minimum protein intake. But anything above that, which is tolerated, can be given. Now, nowadays, a new therapy is coming, which is ketogenic diet. I suppose there are some dietitians in the group, and they probably will be able to help. Unfortunately, what happens is this needs to be started very early in life. So it is like 1 month or maybe 2 months. we start ketogenic diet, and these are the formulas which are available, which are quite costly, but they are supposed to help. I have not used, because most of the patients, in whatever way I am practicing, we don't get those kind of patients who can afford uh, these formulas which are imported. But overall, ketogenic diet is recommended and can be used. Okay. Now, how do we follow up? Follow up will be important by plasma amino acids. Now, every time we cannot do CSF, but once or twice if we do, just to see whether the glycine level has actually come down in CSF. That will be very helpful. But it is not required like every 2 months or 3 months. TMS to use for follow-up is not a good idea, because TMS does not pick up glycine very well. It's a small molecule, small amino acids, and it does not give quantitative assay. So if you are really going to follow up nutrition and glycine level, I suggest proper plasma amino acid level. So we look at the glycine and branch chain amino acids. There should not be any deficiency of branch chain amino acid or tryptophan. CSF can be done once or twice just to make sure that everything is fine. Nutritional parameters, because now we are restricting high protein or any other additional supplements. So maybe we can do serum proteins, calcium, phosphorus, alkaline phosphatase, B12 level, D3 level. Now, this particular line will come in each and every case. So I'm not going to repeat. We just say nutritional parameters. Neurological follow-up, if you are able to do full neurological assessment, or you have a colleague, neurological colleague, neurologist, pediatric neurologist to help you, that is very, very important. And EEG and MRI. Not to give a very dismal picture, but 90% I would say they are not going to do very well. And I have one or two patients where the neurological outcome is quite good, but it's not a rule. Okay, so let's go to the next case. This is 1 month old female child born out of third degree consanguineous marriage, full term normal delivery, cried immediately. Birth weight was 3.5 kg. History of lethargy, vomiting, convulsions on day 7 onwards, and urine ketones were elevated. Next, madam. So we found DNPH, dinitrophenylhydrazine test positive. TMS showed leucine 2400. So clinically, we were pretty sure that this is MSUD. Next, madam. And it was confirmed by GCMS. That is very, very important. We need to confirm. Don't just start treatment based only on TMS. Of course, you can start, but we still need a diagnostic approach, and that is GCMS of urine. Then later on, we do genetic confirmation. So this shows 2-oxocaproic acid, which is a compound needed to diagnose maple syrup urine disease. Next, madam. So we have elevated leucine on TMS, which can be seen in MSUD. And there is a condition which is called branch chain ketoacid deaminase deficiency, where the GCMS will be normal. And that's why I said GCMS is very important. Just leucine elevation on TMS does not mean it is MSUD. Also, there is one condition called hydroxyprolinemia, which has almost same molecular mass, and therefore TMS shows all these things together. So it is leucine, isoleucine, alloisoleucine, hydroxyproline all together. So that's why it is labeled as X-leucine, not just leucine. So diagnosing is pretty easy, maple syrup urine disease, but the long-term treatment is I would say, one of the most difficult things. So here we start with basically low protein diet. Now, when we say low protein diet, it differs from individual to individual. Initially, during emergency, we can stop protein totally for say a day or two. I generally say 24 to 72 hours, nothing more than that. But then we introduce something orally and then slowly increase protein. So low protein diet, which is targeted towards reducing branch chain amino acids, and we supplement with special formulas. Most of the MSUD patients will need formula. Now, this is one question asked by many parents, that do we really need a special diet for all the patients? And in this particular case, I would say mostly 90% children will require. Now, there are different types of organic acidemias where need of special formula differs. But most of the time, MSUD patients will need, if it is a severe form. Now, there are some mild forms also where we may be able to manage with slightly low protein diet and supplementation of isoleucine, etc. Role of dietitian is absolutely important. I think more than a physician, a dietitian should be available for these patients. Almost they need like every month or every 15 days consultation, depending on the weight, depending on the development, depending on the likings of the baby. We need to change the diet. So a dietitian should be very well versed with MSUD and all the calculations. Now, this is difficult to discuss all this in one session, but it will require a lot of calculations. It will require calculation of leucine, isoleucine, and then amino acids will tell you whether we need to supplement. So MSUD formula is necessary, and in some cases we will also add special isoleucine and valine powder. Thiamine we do give, but we don't know how many of them are really thiamine responsive. But generally, long term, we give thiamine something like 300 to 400 or up to 500 milligram. But we don't really try to see whether it is really responsive, non-responsive, because there is no specific test which will clearly tell us that this is non-responsive or this is responsive. So we give it and we don't stop. Now, early on, we need to discuss with family and they also need to take a decision whether liver transplant is entertained, because this one entity or this one treatment is going to change the life of the child. So if you are really thinking seriously of doing it, do it early rather than wasting time and thinking. And that, please consult some pediatric hepatologist or a hepatic team involved with the transplant. And if done early, it gives very good results. I have many patients of MSUD. They have done good transplants very early on life, and they have a good life. So follow up, long-term follow up, because this is one thing, one point I would like to highlight for all the metabolic diseases. One point which I tell them first is that treatment is practically lifelong. Please don't say that we will give it for 3 months, give a trial of 5 days, or we will give it for 1 or 2 years and then we will stop. As long as you have that gene which is defective, your diet will continue. After your treatment with, say, transplant or HSCT, whatever it is, something will change, but still you will still need some medication. So if you do transplant, you may need tacrolimus, you may need steroids, you may need some other care, some other type of diet. But none of these conditions, even if transplanted, liver transplant, you're not correcting metabolites everywhere in the body. So gene defect is still there in the brain, it is still there in the heart, it is still there in the kidneys. And we may have some metabolism going on there, and some metabolites will be there. So diet may be required. So it is not that we are doing transplant to give them a good diet. We are doing transplant to prevent brain damage. So this concept we have to understand. I have seen some parents will say, then what's the use of doing liver transplant? If we have to give a diet, why do liver transplant? It's not that. We are going to prevent any further brain damage. And if required, you do give diet, you do give medicines. So especially it is true for organic acidic. So in follow-up, we do plasma amino acids, quantitative. And if you have availability of allo isoleucine, that's a very good marker. It really helps in understanding which patient should go for liver transplant and all. TMS is required because now we give low protein diet and sometimes carnitine is very low. GCMS to see oxocaproic acid, nutritional parameters, as I discussed previously, and neurological assessment. And generally, I say in India, we recommend once in 3 months. When I was in Germany, they used to say do it 1 weekly or 1 monthly. But here, patient has to bear the cost. So it's not possible. It's some trade-off. We may do it early, we may do it little late, but at least 3 monthly is a good idea. Next, madam. Next. Okay. So we go to third case. 2.5-month-old female child born out of third-degree consanguineous marriage, had his intractable seizures, hair fall, no failure to thrive. and there were skin lesions like eczema, and no significant family history at that time. But then later on, they had two more kids, and one of them was this condition. So next, madam. So basic investigations we did showed a high ammonia, high lactate, low blood sugar. And when we did TMS, it showed C5OH elevation and biotinidase was very low. So I am not discussing too much about the diagnosis. We are discussing about management. GCMS showed high, isovaleric acid. Next, madam. So this is the baby. It's very typical. So once you see a child who is doing pretty well physically, good weight gain, no dehydration, hair loss, and seizure starting little later, around 2 months, it's almost sure that it is biotinidase deficiency. So this is the question again. Do we need lifelong treatment? Yes, we need a lifelong treatment. Do we need special diet? No. So this is one condition where we do not need any special diet. And I have not seen or heard about doing any kind of transplants in these patients. They do very well with the biotin. Now the question comes is how much? We start with 10 to 20 milligram per kg per day. 10 to 20 milligram per day. But most of the patients I have seen will need something like 40 milligram. Sometimes we need up to 80. So it depends on each individual patient. Initially, if carnitine is low, we do give carnitine, but later on it is not really necessary if child is doing well. Soda bicarb supplement also initially is required, but later on it is not really required. Multivitamin may be given, but what they need is anticonvulsants. So long-term treatment, if you see for biotinidase deficiency, is very, very simple. I must be having more than 70, 80 patients of biotinidase deficiency. And once they start biotin, they hardly follow up. And I have children who are now grown up. They have their own businesses. They have got married. They have their own children. So life is good. And I would say this is one of the best conditions to have. One complication which we need to be aware of is deafness. So many of them develop uh, cochlear damage very early in life, even before we start treatment. So always do BERA or hearing test and make sure that there is no deafness, because sometimes later on we feel that, oh, it's because of medicine or something. So BERA is required in very early, and maybe you can repeat it once or twice later on just to see that everything is settled. Next, madam. And here we have follow up with TMS and GCMS to see the level of C5OH and isovaleric acid. Biotinidase enzyme we can do, but this level is never fixed. If you do it 10 times, you will get slightly different values, but the range remains same. If it is severely deficient, it is severely deficient. Since we are not doing any protein restriction, rather I would say no special diet, we are little relaxed on nutritional parameters. But if child is taking some protein restriction or some dietary restriction, we can do usual nutritional parameters. Neurological assessment is very, very important. Many of them need help with occupational therapy, physiotherapy, but they do develop very well. So I would say like 70-80% of the children who have not much of brain damage will have excellent neurological outcome. Just be careful with hearing. So BERA and audiometry should be done. And couple of my patients are having hearing aid. One of them planned for cochlear transplant, but the cost was too high. And then later on, child started hearing. So parents gave up, and the child is now with only hearing aid, something like 40 to 80 decibel loss. And she's quite doing pretty well. The same child I am talking about. Next, madam. So this is a 35 days old male child born out of third degree consanguineous marriage, 38 weeks, and birth weight was 2.8 kg, presented at about 10 days of age with vomiting, altered sensorium, drowsiness, and seizures. Metabolic acidosis and ketosis was detected, and one previous baby had expired in the first week of life. I think parents are in the group, in the participant. So I'll thank Mr. Udar. Okay. So this child had skin changes of protein malnutrition because baby was admitted in some other hospital where child was receiving only IV fluid and very, very low protein. So there was protein deficiency or branch and amino acid deficiency. So one point in the acute management and even in the long-term management is do not over-restrict proteins. Most of these cases require some protein restriction and it differs from patient to patient. So please mark my word. It's not a standard rule that you give 0.75 gram per kg per day for every child. It can be 1 gram, it can be 1.5, it can be 2, and some patients do even better with slightly higher protein, 2.5. So it differs from patient to patient, it differs from condition to condition, and it differs from time to time. So just take help of a good dietitian, which is absolutely important here, and they will assess and decide what to do. And of course, metabolic reports will help you in guiding those things. So those reports are really, really very important. So in this child, we had like, it's a long follow up. They are with me since 2012. But just see the first line, madam, next slide. The first slide or first line, serum protein was just 3.6 gram and albumin was 2.3. Even though the methylmalonic level was low, but there was nothing like child had very low carnitine, very low this thing, protein. So we suggested to introduce milk, breast milk if possible, and then slowly manage. And parents are very, very cooperative. Both of them are teachers and they followed up religiously. And next slide, madam. So we did genetic studies also to confirm mute deficiency is there, but I cannot show you the picture, this thing, actual defect. But these are the pictures of the baby, and this is with consent of the parents. So just see the first slide and the next and the next. Just go ahead, madam. So one more. And this child just this one. So this child is doing extremely well. I am very, very happy. Parents are really very supportive, and I would say they follow up everything very, very properly. And the results long term. Now we are talking about long term management, and this is the result. So one thing which I always suggest, regular follow up is absolutely crucial. And second thing, never give up in the first few days of life. You always try, at least try. I am not saying 100% children will survive, but who will survive, we can't guess on day one or day two. So some of my colleagues or friends say, "Ah, I have done negative counseling, I am sending it to you." So no, I think it's better we don't give that kind of counseling. Let's wait, let's see the course, let's get the genetic report, what kind of mutation is there, or if we can do any enzyme diagnosis, so how low it is. After that, we start discussing. So day one, if somebody says, except for glycine encephalopathy, I would say we don't give any bad prognosis. So this child is doing extremely well. So next slide, madam. So this is the gas chromatography, which clearly shows methylmalonic. And I am covering everything, all the organic acid, major organic acid in this group. So next slide. This is propionic acidemia. Next is isovaleric acidemia. And all of them have almost the same kind of management. So first is low protein diet. And as I said, don't give too low protein. That means we need something like 1.5 to 2 gram per kg per day. Special organic acidemia formula, OAC or whatever is available, it's not required for all the children. So it is generally said that 75% of propionic acidemia patients will require formula, 50% of methylmalonic will require formula, and 25% of isovaleric acidemia patient will require special formula. Rest can be managed with a low protein diet, which is like most of the Indian diet except for non-veg is low protein. And we are managing it fairly good with these. And if you really need special formula, it is for propionic and methylmalonic, XMTVI, that's the short form that I use. That is no methionine, threonine, valine isolase. Then hydroxycobalamin. Hydroxycobalamin injections are very, very important here. The dose is calculated per week, 1 to 2 milligram IM per week. But if it is cobalamin defect, especially cobalamin C, will require much higher dose. You may need something like 10, 20, 30. One of my patient is taking 70 milligram cobalamin every week. That's the kind of calculation. Not all cases are B12 responsive, but problem here is we don't do B12 responsiveness studies. Generally, babies are or children are bad when they come to us, and that time we don't want to take the chances, so we give B12 and we continue with all the other medications like carnitine, biotin, bicarbonate. But if child is a cold case, comfortable, we can do B12 responsiveness. So you do one methylmalonic or propionic this thing levels and then give injection, and then after 1 week you again assess the level and see whether it is responsive or not. But generally these kind of things are not done in India. We don't have that time and patience, so we give, but it can be done. Now, here again, we need to discuss liver transplant early on. Not all patients of organic acidemias, especially propionic acidemias and methylmalonic, will require liver transplant. And most of the isovalerics do very good without any transplant. So we don't really discuss liver transplant in those patients. Propionic will be high on the list, and then comes severe form of methylmalonic acidemia. Problem with this is it does not supply enough, I would say, enzyme. So there is still some amount of acid produced. So even if we do liver transplant, it is never 100% recovery. So we may need supplementation of carnitine, we may need small amount of formula, or we may need some amount of protein restriction, and plus tacrolimus, prednisolone, or whatever your hepatic surgeon or team suggests. So it is trade between one disease to another. We just improve the diet. We don't give total free hand. And what is important is why we are doing it is to prevent neurological damage. And that is the idea which parents must understand, that it is not that we are trying to give this child everything what he likes, but we are trying to save his brain and his kidneys. So that is the idea of liver transplant, and that should be discussed. Next, madam, follow up. So follow-up pattern now you must have understood remains the same. We look at the basic problem, that is propionyl carnitine or isovaleryl carnitine, and then GCMS to look at the organic acid. We can quantitate them, methylmalonic and methyl citrate levels. Amino acids, this assessment is very important. And please don't rely only on TMS for amino acids. So we need actual branch chain amino acids, glycine levels, tryptophan levels, and other things. Nutritional parameters and neurological assessment like any other case. In organic acidemia, additionally, cardiac and renal assessment becomes very, very important. So these patients are taking low protein diet, and their serum creatinine or BUN will not be very reliable. So cystatin C is the marker which is used. Special biomarkers I have mentioned. And serum FGF21, that is also used to understand the mitochondrial function, because that is disturbed here. And this gives beautiful follow-up and understanding what is happening with the child. So next, the fifth case. Madam, if time is short, you just tell me, because I don't have watch in front of me. Okay.
I'll inform you, sir. You can.
Okay, madam. Okay, thank you. So this is case number 5. This is full-term LSCS non-consanguineous marriage. Birth weight was 3.5 kg. And child developed lethargy, refusal to feed, altered sensorium on day 3. And one elder female sibling is normal. So sepsis workup, etc., which was done negative. So obviously suspected inborn error. Next, madam. Next slide. And what we found was high ammonia, mildly elevated lactate, because child had some kind of cerebral edema. But ammonia, if you see, is more than 10 times the upper limit. So we started suspecting urea cycle defect. Of course, there was alkalosis, so that also helped. Next was MRI done, EEG showed burst suppression pattern. So here comes the standard pattern for high ammonia. We do orotic acid and plasma amino acid, which showed elevated orotic and elevated citrulline and normal ASA level. So our diagnosis, biochemical diagnosis, was citrullinemia type 1, which is ASS deficiency. Confirmation with genetics. Done. Next. And long-term treatment. Now, a child was in hospital for something like 10-15 days. Very good tertiary care hospital, one of the big corporate hospitals in Mumbai. So they managed it beautifully. Fortunately, did not require any dialysis. But in high ammonia cases, I would say don't wait for dialysis. If it is somewhere around 200 plus micromole per liter, start preparing. If it is more than 400, immediately do dialysis, whichever dialysis is available, whether it is peritoneal dialysis or hemodialysis. So that we will not discuss. So long term, yes, protein restriction is required, and this is very, very important in this kind of patients' urea cycle defect. So I am grouping everything in one. Most of the patients will require low protein, and rarely ever I have seen child doing good with fully normal protein intake. So some restriction is required. 1.5 to 2 gram per kg. UCD formula, many of them require, but not 100%. Some of them can still do okay with just low protein diet, but that risk I would not take initially. So if anything has to be done, I will say just wait for 1 or 2 years, let brain development be completed, and then you can plan whether you can reduce or you want to reduce. Special formulas will not have any citrulline, arginine, or ornithine. Then ammonia scavengers like sodium benzoate, phenyl butyrate. Now that is also available. Arginine in cases except for arginemia and some vitamins and calcium supplement. Here also liver transplant is one of the good options, and we should discuss very early in life. And many of the urea cycle defect patients do very well after liver transplant. And fortunately, outcome of urea cycle defect with liver transplant is much better than organic acidemias. So I'll say if you have a choice, a patient can afford and patient is good enough in say general condition, think about liver transplant positively, because that is going to change child's life and even diet and neurological outcome. So liver transplant is recommended and should be explored. Next, follow-up is as usual, we do the basic profile. TMS is done because to see carnitine level, orotic acid level, plasma amino acid. And I've seen many people asking for urine amino acid, which is not routinely required except for cases of lysinuric protein intolerance and HHH syndrome. Nutritional parameters and neurological assessment like any other case. And ammonia. Now, this point is absolutely essential that we tell parents that to do ammonia regularly in a nearby lab, but insist on report within say half an hour or say 40 minutes. If it is delayed further in assessment analysis, it may not give a good result. So identify a lab which can do, and don't change the labs frequently, because it's difficult to compare between 2 or 3 different labs. So I suggest to identify one good lab and continue to do ammonia level there. And next, quick words about phenyl butyrate. Now it is available in India. I don't know about other neighboring countries, but should be available because the supplier is international, one of the international pharmacy and dealers. Cost is high, but it is good for emergency treatment. So many of the serious patients initially, even including organic acidemias, will benefit with the sodium phenyl butyrate, 250 milligram per kg per day. Unfortunately, I am not in a real good favor of using it a very long term. One thing, because we don't have that much experience. The second thing, lot of side effects are known, and we are managing beautifully with arginine and sodium benzoate. So I personally don't prefer for a long period, but of course, in emergency, we have used. Next, madam. There are a lot of side effects. I am not going to read out all those things. You can see in the text. So there are plenty. Now, this one, arginine is easily available. That's one thing, easily available, but sometimes it just goes out of stock. So when you are having a patient and long-term management is planned, just order it and keep it for say 1 month or 2 months supply. It is available in India as a small sachet of 3 grams powder, which is actually 5 gram powder, but arginine is 3 grams. Dose is 100 to 250 milligram per kg per day. Your pediatrician or metabolic physician will decide the dose. And it is helpful in the urea cycle management, but also it is helpful in other conditions like melas and pyridoxine dependent seizure, sometimes in glutaric aciduria and creatine transporter defects. So it is a good medicine, easily available, not very costly. Unfortunately, injectable form is not yet available in India. Citrulline in OTC and some cases of CAVA or carbonic anhydrase 5A deficiency, we do use citrulline. The dose is 170 milligram per kg per day in 3 divided doses. This is again a long-term treatment. So it's not 3 days, 5 days kind of treatment. If we start, we generally give it a pretty long or probably I will say lifelong. So this should be available easily. Some of my patients are getting from company which produces these amino acids packets, small packets. But this is also available in some kind of health malls or shops, bodybuilding shops. So they have large jars. I am not sure about the bio availability. So I suggest to my patients go to a pharmacy rather than health malls and use it. But sometimes it becomes much cheaper in the health malls. And for older children, like say 10 years or more, we can try that also, no harm. Then there is another medication easily available now with the same international pharmacy is carbamyl glutamate that can be used for CPS deficiency, propionic acidemia, or carbonic anhydrase 5 deficiency in the initial phases. Dose is 100 to 300 milligram per kg per day. Again, even it is costly, but results are excellent, and this is sometimes used in a long term. So it's used in emergency as well as in long term. Tablets are available. Unfortunately, no injection or powder form I have heard, but maybe somebody will produce it. So we will not be discussing. Just let's go to next 2, 3 slides. Corporate. This is one thing which is required for hyperammonia, even though it is not long-term treatment, but it may be required frequently. So we have a couple of patients who go into hyperammonemia crisis often, and they require some kind of support, dialysis support. And preferred is like easily available peritoneal dialysis, but other forms also can be used, whichever is available. So just remember those who are like parents who are attending, just keep it in mind. If ammonia is going above 400 micromole per liter, be ready for dialysis. Dialysis will save the child. So I'll just give an example. We had one patient, MSUD patient, recently, like he was 16 years, and I am seeing him from day one of life. And this child had leucine level of more than 3000. And I suggested, please do dialysis, don't waste time. And parents kept thinking, okay, let's see tomorrow what happens. Doctor also nahi dikhte hain. And ultimately, after 3 days, child expired. So this is a 16-year-old child who was doing excellent. He was doing neurologically quite good. I would not say 100%, but IQ maybe around 70, 80. And he was quite self-sufficient. And we lost this child just because they wasted time in thinking and deciding about dialysis. So please don't waste time on dialysis. Even in long-term management, it may be required. So next slide, management, nutritional aspect. So this is a little important. So we provide adequate calories. In hyperammonemia cases, the first thing is to give enough glucose or enough calories and then start managing other things. So this supplementation, this is only point I wanted to highlight. And even in long term, when I say low protein diet, we focus mainly on protein, but we forget about calories. So those dietitians who are in the audience, I would just like to highlight one thing. You always calculate calories, but insist or highlight that, and parents must understand that calories are as important because they are protein sparing. And if you want the child to develop properly, you need adequate calories. So calories are also important, not just protein. So take care of calories. Just one more slide about ammonia business. And this is a new medication coming up. Sometimes parents ask me, and that's why I have included this. This is a new medication, which is a glycerol phenyl butyrate, and it's a kind of oil good for very long term treatment because it is, I would say, easily acceptable, but cost is horrible. Just next slide. And if you see, this is from Sigma, which supplies the basic material. And I can read out the cost is for 25 ml, it is 37,000 rupees. And this slide is, I think, some 2-3 years old. So practically daily, you will need 35 to 40,000 rupees. This is in US. So by the time it comes here, you have custom duty, you have courier expenses. The cost goes in lakhs. So it's very easy to read in some research paper or some news and some marketing thing and start thinking, oh, I will use it. But it may not be applicable in our patients. So try sodium benzoate first, if not sodium phenyl butyrate. If not, and if you can afford this kind of cost, surely try this medication. But as of today, I don't have anybody taking this. So this is little difficult cost wise. Next. So next we'll go. So we discussed this.
So we'll
There is
discuss
one
one last case, sir.
Okay. So just quickly, there is a new therapy coming up. Just this is very important that there is a kind of dialysis available with liposomes. So liposomes are protein. Next slide. So it's a kind of molecule. Next slide, madam. So it has one hydrophilic this thing head and hydrophobic tail. It will absorb ammonia, and there are different types of material. So this is number 6. There are 1, 2, 3, 4, 5, 6. Liposomes are used as a peritoneal dialysis fluid, and it will reduce ammonia. It remains in circulation for a long time. So this is my last case. How many minutes do I have? So
one last case we will take and then go for QA, sir.
okay. So this will take 5 minutes. So this is 2-year-old male child born out of 3rd-degree consanguineous marriage. This is anyway last case. So he had failure to thrive, irritability, delayed motor milestones, hypotonia, rickets, and there were no seizures or any jaundice. Previous 2 children expired with liver disease. And I'm coming to diagnosis straight away. We diagnosed this as tyrosinemia type 1, which is quite common in India. I don't know whether it is seen in other neighboring countries, but in India we see, and there are hotspots like Gujarat in like Patel community, and we see in Rajasthan, in Maharashtra. So these are quite common. And if you see, just next, madam, next slide. Next slide. Yeah. So here we found urine succinyl acetone to be very high, 296. Next slide. And confirmed the diagnosis by genetics also. Next. Now here comes the long-term treatment just before that. Long-term treatment. This is again absolutely lifelong treatment, no shortcuts. You start immediately. Unfortunately, I saw one patient from Karnataka diagnosed in newborn screening, and they came to me for treatment at the age of 1 year. And what they were waiting for, I don't know. But for 1 year, no treatment was given. So please, once we diagnose, start treatment immediately. NTBC is available in India. Cost has come down. Dose is 1 to 2 milligram per kg per day, and it is a lifelong treatment. There is absolutely no shortcut. Low protein diet is also again lifelong. Of course, you need special formula because now we are giving NTBC and we expect tyrosine to increase. So we give tyrosine, low tyrosine formula. Correction of acidosis, vitamin D supplementation, etc. is required. So this is the child. Next one. When I saw, and after 6 months, next one. Excellent recovery, good. The only thing, when we start NTBC after 1 month of life, the chances of hepatocellular carcinoma are there. Very early treatment, like in newborn screening, if you detect and start, chances of HCC also goes down pretty well. So if you are late, keep in mind HCC, which cannot be prevented by NTBC. Unfortunately, this child also developed liver cancer. He was operated, liver transplant was done, and he's doing extremely well. Now he's an adult, goes to college and does everything absolutely normal lifestyle. So next, madam, 2 slides, one more. Long term. Next one. So this we discussed. So we follow up in the usual way. Because child is on low protein diet, we look for carnitine, we look for succinyl acetone quantitation, plasma amino acids, and neurological assessment, nutritional assessment. And here hepatic assessment becomes very, very important. So sonography, CT scan, MRI, and some biomarkers like alpha fetoprotein, etc. And NTBC level, the drug level is absolutely important. Just next, a word about ketogenic diet for those who are in the group, parents especially. Discuss with your doctor if child has repeated seizures. Many metabolic conditions can be treated with ketogenic diet. Next slide. I am not going to list everything. And one last slide, just permit me one more slide important. Just go to next. This is what I want to highlight. This is the crux of everything. That because these small molecules, we think that, okay, we can start with treatment anytime and child will do well because now you have started like say PKU or UCD or tyrosinemia or MSUD. It is not like that because these molecules or these amino acids, next slide, when they are in circulation, next slide, in a high concentration, next one, now this is the slide, they become aggregated. It becomes amyloid like structure, and that goes and damages neuronal cells, it damages DNA, it damages RNA, and this damage is permanent. So now if you start treatment after say 15 days of life, whatever has damaged is remaining there, it's not going to come down. It is probably your treatment will prevent further damage, but to avoid this also, we need to start treatment absolutely early in life. Just next one. So just keep this picture in mind. These are the aggregates, say phenylalanine, or there are other materials which will become amyloid-like structure. Next one. And they will keep on damaging brain. And there is no way we can remove this from your circulation or from brain. So start treatment absolutely early. Newborn screening is a must. Once you have that newborn screening, immediate treatment. And this is what parents sometimes ask, like, oh, we started treatment, I'm doing everything, diet and whatever medication you have suggested, but still the neurological condition has not improved. And why? Because of this. Because whatever has happened initially, you may see some structural changes on MRI, but these micro changes you cannot see. For that, you need electron microscopy. It can be done, but we generally don't do it. So uh, this is the end of my talk. And before these are the amyloid structures. So the beautiful pictures. It is done in Gujarat. So just few words I would say. For long-term treatment, remember treatment is lifelong. There is a regular follow-up required. There is no shortcut for that. Follow up with biomarkers. There are many biomarkers now available and many more are coming. Dietitian is absolutely crucial in the treatment. So please involve a good metabolic dietitian. Genetic studies are required. Some people try to defer it or delay it because it may change diagnosis or it may give some support or some additional information. So go for genetic studies and don't stop breastfeeding just because somebody has said, except for galactosemia, sometimes VLCAT deficiency and hyperlipidemia cases. Otherwise, any organic acidemia, urea cycle defect, MSUD, they will benefit with some amount of breast milk. And that dietitian will help you in calculation and in management. So please don't stop breast milk altogether. So in early life, first 1 or 2, 3 years, this is a lifeline. Thank you, madam. I think I have covered my talk completely.
Yes, sir. Thank you. Thank you so much, sir. Your talk was really beneficial because what we really read in theories and your real life experiences as a practitioner with metabolic diseases would definitely make a difference for all those who are in the audience to at least think from some of the points which you have said is really practically applicable whenever they see a child or a patient who is presenting manifesting with inborn error in metabolism. So I'll start reading the question. So what is the role of sodium phenyl butyrate versus sodium benzoate in UCDs? How much sodium phenyl butyrate is better than benzoate?
No. See, if we talk about the practicality, sodium benzoate is much better because the cost, first thing is the cost. See, it is going to be long-term treatment. So anything which is costing 20 gram is going to cost you say 12 rupees or say $0.25 or something like that, versus you start thinking about sodium phenylbutyrate, one bottle will probably cost you 85,000 rupees. So in a month, if you are spending something like less than 100 rupees versus something which is like almost a lakh of rupees, it's not a good idea that all the children will require sodium phenylbutyrate. So this is, at least in India and probably neighboring countries, it will be a second choice. Second thing, side effects. So side effects of sodium benzoate are not much. One thing, it is gastric irritant, but that we know how to solve that issue. Dilute it, and maybe you can add honey or something to reduce that and give some lansoprazole. It will help. But sodium phenylbutyrate has lot of other issues. So you can go and read. It has endocrinological side effects. It has cardiac side effects. It has fluid retention, lot of metabolic acidosis. It produces acidosis itself. So sodium phenylbutyrate, as it is okay in initial phases when child is not responding to sodium benzoate. So my line of thinking is very, very clear. I start with sodium benzoate. Next, if not responding, if dialysis is not helping or whatever, if you want to really add something after, say, arginine, I will think about sodium phenylbutyrate. So that comes third or fourth in the line. I don't see any great advantage over sodium benzoate. So it's not that it is better than sodium benzoate. It is just the additional compound that is available. So I would say it is one additional support that you are having, but it cannot replace sodium benzoate.
Yeah, moving on to next question, sir. Can new keto acid appear in urine GCMS after thiamine dose? This was not appeared in initial urine workup.
No, no, sorry. What does it? So initially it was not seen and later on it has come.
Yes.
Okay.
After thiamine dosage, initially
No, I
this is
think thiamine probably will not do much about. See, ketones or keto acids, they are dependent on the branch chain amino acid, because branch chain amino acids get converted to keto acids, and it depends on the basic pathology. So initially, if child was under control, or maybe there was not much of a stress, and later on the stress has come, or there is some kind of decompensation, you will see ketones and keto acids in urine. But I don't think it is related to thiamine anyway, whether you give it or not give it. We give thiamine thinking probably it will help. We have no evidence as such. So I think appearance of ketone probably will not come because of thiamine. If at all, it may reduce because of thiamine, but appearance later on is probably suggesting that there is a stress, or the branch chain amino acids have increased in number.
Yeah, just to add to this, what is the importance of collecting critical sample for initial diagnosis of?
Absolutely, absolutely important. Absolutely important. There is no two, I would say, way of thinking. See, if you can collect, as I always say in my lecture, whenever you have a sick baby, collect 3 tubes of blood, one heparin, one EDTA, one plain, and collect urine. If you have done lumbar puncture, save that sample, CSF sample. Now, all the sample should go in the fridge. Sometimes parents are not ready, sometimes you don't have logistics ready, sometimes you are yourself not very sure whether it is metabolic or not, but save this critical sample. We don't lose anything. Hardly this will cost you 100 rupees at the most. Once the sample is saved, you can start your treatment. It will not alter your biochemical parameters much. If you need metabolic studies or genetic studies, you can send it, say, next day, third day, fourth day also. No harm. Of course, it cannot be kept for months together. So there is a time frame, 1 or 2 days or 3 days. But if it is safe, it's saved on filter paper, say, actual blood which is taken directly from baby is taken on a filter paper. So there is no anticoagulant there. It will not interfere with anything. This can be used for many things. So this we use for, say, TMS, amino acids, even genetic studies. Saving one filter paper at the most will cost you 25 rupees. And suppose it is not needed later on, you can discard it. But if it is needed, unfortunately, baby expired. All these samples can be used even after the baby's death. Or if baby is critical and now you want to do it immediately, you can send it. So collect critical samples in all the cases and then save it. and then next day you can
Sir,
decide.
just to interrupt, many of the times from a very peripheral setup, they would have referred after giving IEM cocktail. So,
Doesn't harm that. See, diagnosis will not change. I'll give you an example. Suppose there is a MSUD patient, and MSUD patient was very bad. Somebody started IV fluid, given thiamine injection, and child has come to you in a critical state. If child has totally recovered, totally improved, then I would say maybe we will not pick up. But if child is symptomatic, that means there is still some metabolites there. Okay, the values may come down from 2000, it may come down to say 1800, but it is still more than say 300, which is a normal range. So you can still pick up. The levels will differ, but the diagnosis will not differ. So even if critical samples are not collected, nothing to worry, not to panic. Only condition where critical sample and the normal condition sample differs is say ketolysis defect, where child was in ketolysis, child was sick, you given IV fluid, child has recovered totally, gone home, and now you do it, you may not see any ketones. But most of the cases like organic acidemia, urea cycle defect, we can still pick up. So levels will change, but the diagnosis will not change.
yes, sir. In Indian perspective, how many children born with IEM annually? And what do you say about the role of universal newborn screening and newborn screening in NICU? And is Indian companies making perfect diets? So we have many in the list.
Yeah. So see, uh, roughly it is said 1 in 1000 newborns, say we have 25 million babies, okay, born every year, roughly. So we think about 25,000 babies with inborn errors of metabolism, which is the list of newborn screening, which is something like 45 conditions. Now, if you include other conditions, now we know there are 2000, at least 2000 inborn errors of metabolism. And you add all those, maybe we are dealing with something like 1 in 200 or 300. There may be some super rare conditions, there may be some which is common and we are missing. So incidence wise, it is high. You take any country, whether it is Sri Lanka, Indonesia, Philippines, Thailand, any, India, Pakistan, Bangladesh, any in this zone, I would say there is something always there 1 in 200 to 300 roughly. Okay, every country, every location will have slightly different. So it is important to do newborn screening. And I personally feel if you are doing newborn screening, why do just one or two? Because your efforts are the same. Blood collection, collecting on filter paper, sending. Your efforts in logistics, you are explaining to the parents is the same. So why not do full? Instead of just doing one, say thyroid or G6PD only, if you are doing all that effort, it's always better to do full or what we call expanded newborn screening or comprehensive newborn screening. Now the things are changing. You must have heard people are now doing newborn screening by metabolomics. There are new ways of doing by genomic studies where 160 or 170 metabolic diseases are covered. So pattern is changing and it is going to come in India, and those who can afford will definitely go for it. The only thing, it becomes universal only with the support of government. We cannot expect from everybody to shell that money out.
Yeah, is the Indian company like which would be preferred for the diet?
See, this is an open forum. I cannot officially say any name here, but offline we can discuss that. But there are one or two good companies, they are making diets. Now problem with diet is we must remember these are all chemicals. This is not a normal food. Okay, so they are not tasty, they are not chocolates, so children will not like it. The palatability is much less than the international brands, so that one fact we need to accept. But the cost factor, if you take any international brand, one thing, getting them in our country or neighboring countries is difficult. Second thing is the cost. It is going to cost us 5 times more. Any tin which is costing here about 1,000 rupees will be about 5 to 6,000 rupees from say Germany or US. So I personally like start with Indian companies. There are two at least, one in Bangalore, one in Mumbai. And if they can afford, and if child is not taking these, then I give them option. Okay, you can import it from your own sources. And I have a couple of patients, those who import regularly. But number, I would say 98% are managing by Indian diet, and I am happy with that. So overall, they are good.
Sir, since
And
it belongs to group 2, how would like
group 2 is what you are talking about. Rare disease
since
support.
they're group 2 category, sir, how will the government be able to help or assist in this
I think
regard
yes,
with
it
respect
is.
to dietary
Yes,
support?
it is. Yes, it is expected that they should support this. And what I think they are suggesting is 50 lakh rupees for 2 years. But they need to go to a center, nearby center, which is government recognized, and they ask for these things. I'm not sure that everybody is getting, but some of them are getting. Some of them are even getting NTBC, some of them are getting even cystagon for cystinosis. So support is available. It may not be for all the patients right now, but the spectrum is increasing. And same thing for transplants, liver transplant, kidney transplant, and all those things. There is a lot of support. May not be for all the patients, but at least I think 50-60% patients are getting. You need to approach the right center, and they can do it.
So what is the role of liver transplant in arginase deficiency who has significant neurological involvement?
No role, madam. Unfortunately. See, once you refer a patient for liver transplant, it's not me, it's the liver surgeon who decides. Okay. And their views are very clear. If there is a neurological damage already, what are we going to achieve? So the thinking is slightly different from the surgical team point of view, which is right, I would say, that you are making an effort, you are putting some 30-40 lakh rupees, somebody's liver you are compromising. And there are a lot of post surgical treatments involved. And if you're not going to really achieve a great benefit out of doing such a procedure, some parents do ask for it. And I have seen one or two patients doing liver surgery, like liver transplant. But overall, I would say if we want to do liver transplant in Argines, do it very early in life, not late.
So we have one more, but it's not a small molecule. If you, it's okay, you
Yeah,
could
yeah,
take it.
please. Yeah.
MPS, what are the current best practices for early management? How to tailor the treatment approaches?
Oh God, it's a very, very big question. I think this will be a lecture. Is Imalke there in the audience? I think maybe is one of my friend who is trained in LSDs in UK from Sri Lanka. So see, problem with LSDs is, yes, of course, diagnosis is pretty easy nowadays with lot of enzyme analysis and genetics. So one thing is, if you suspect, you start very early. Unfortunately, the next thing which comes is enzyme replacement therapy, which is not easily available. So some of the patients initially got it from a company, and they gave it on, you can say, compassionate basis. Some of them received on partial payment basis, and now government is supporting some of the patients. And just a moment, I think Imalke is there in the list. I am in, but not allowed. Okay, just oh, okay. Anyway, so in that case, what happens is the availability of ERT becomes a limitation. Those who can afford should go immediately, and some of them will benefit by HSCT. So MPS type 1, people are doing for type 2. Now I have heard very good results for type 4 also. Unfortunately, type 3 is the group which is left out. There is ERT coming for type 1 and type 2, or A or B type of MPS 3. But type C and type D, there is no specific ERT as of available. I am using Genistin, which is isoflavonoid, soybean isoflavonoid, and pretty good results, especially for patients where we have high heparan sulfate. So you can use an MPS 3 mainly, but MPS 2 and MPS 1 also it helps. It reduces the dysmorphic features, coarseness. It reduces this adenoid and tonsillar enlargement. Joint stiffness is improved. So children are better, but they are not normal. So here we have all these limitations. Of course, they will need supportive care for cardiac involvement, for other neurological conditions, ADHD they may be having, and joints problems, so orthopedic support. Beyond that, I would say there are quite a lot of limitations, and there are newer enzymes coming in. Um, Maybe one day we can have good session on MPS or lysosomal storage diseases. So I think, in short, I can say this
Yes,
much.
sir,
So ERT,
we can have an extensive session exclusively on
mm,
LSDs itself so that the audience would be benefited.
yeah, good. Anything else, madam?
Yes, sir. Thank you so much, sir. On behalf of Organization for Rare Disease India and all the audience, we are extremely thankful to you for sparing your valuable time in spite of your extreme commitments and giving us a very clear picture of the through clinical cases especially and stepwise approach and also the monitoring long-term management through your experiences. This would have added a lot of information to the audience and all the participant. I thank on behalf of all of them for being with us and providing this insightful session, sir. Thank you so
Thank you very
much.
much, madam. Thank you. Thank you very much.
So if any of them have still queries, they will be mailing us and we will be redirecting to you.
Yeah, yes, yes, no problem. You can send on my WhatsApp or my email.
Yes, sir.
WhatsApp will be much faster.
Yes.
Okay. Thank you very much, madam.
Thank you so much.